Welcome to the Alder Hey Emergency Department for Year 4 medical students at the University of Liverpool. This is video 2 of 2, and this is going to introduce you to some concepts that our patients face when they come to the emergency department. We are going to talk about the consideration of children in emergency departments. Hopefully at the end of this you'll have an appreciation of the impact of acute illness on a child and the family, and some understanding of additional stress that acute illness places on a child with a chronic condition. There are some considerations of children in the emergency department. The main thing that we do in the emergency department is diagnose. Patients present with undifferentiated injuries or illnesses, and it's our responsibility to find out what's going on. And there's a process by which we do it, which is as you know, history taking and examination, plus or minus investigations. But the whole part of this starts in the triage area. And triage is trying to understand the severity or the urgency of the illness or injury that they are presenting, regardless of what that is. Diagnosing doesn't often happen in triage, but it can. But a further history and examination is taken by the clinician seeing the patient. Pain is something that's really important to address in a child. It's really important that we understand and how to assess pain, and hopefully you'll see that when you're during your placement in triage and following a patient through. How we treat that pain, what we treat it with, how we explain that to the patient, and then how we assess that pain relief, or that those pain relief measures have worked. It's not always pharmacological in its nature, and hopefully you will see other means of non-pharmacological methods of pain and distress relief. Something that we also do is we also try and understand and identify which child of all of the children that we are seeing is the child who is actually really sick, and that they're presenting earlier in their presentation before that they have decompensated. And spotting the sick child is a particular skill, and there are pathways and procedures and policies which try and mitigate for this. Safeguarding is everybody's business. There are safeguarding checklists that happen in triage, but we are always on the aware that safeguarding issues can happen to children, particularly with unscheduled and emergency situations. And it's important to note these, document them, and follow procedure to ensure that children are kept safe. For further information on triage, pain, safeguarding, and spotting a sick child, please use the QR codes which links to documents which will provide some more information for you. So now we move on to talk about the impact attending the emergency department has on patients. Patients don't plan on coming to emergency departments in their day. They don't wake up in the morning thinking, right, today I think I'm going to go to the emergency department. And so not only then are children and families concerned about the physical medical health, but there's a considerable amount of emotional worry about what will happen to the child, and indeed the child themselves. What will happen to me? I'm in a place where I wasn't planning on coming to today. And we're going to demonstrate this with two cases. So first is Bobby, and we're going to discuss Bobby in the context of acute illness in a previously well child. Bobby's not feeling well. He's a 3-year-old boy, and he told his parents that he has a funny feeling in his chest. They went to the walk-in centre the day later, where an assessment was made, and the walk-in centre contacted the ambulance. An ambulance arrived at the walk-in centre to pick Bobby up and take him to our emergency department, and he arrived in our resus area. He said that he was feeling unwell, and Mum and Dad, who were present in the consultation and the attendants, looked quite worried and quite tearful about what was happening to Bobby. On arrival to the emergency department, to our resus area, and as you can see from the picture, there are several members of staff who need to be present for the care of an acutely sick child. In this photograph, there are at least 8 members of staff. In a full resus situation, sometimes there can be 10 or 20 members of staff who need to be present in order to assist that child and the family. Picture the scene: a young child, parents who have not planned on attending the emergency department that day. The child is feeling very unwell, and then they are faced with a room full of strangers. It's anxiety inducing, and there are ways that we need to recognise this and address this. An ECG was done on Bobby, and Bobby's in SVT. He's experiencing a supraventricular tachycardia. For treatment of this, Bobby needs an IV cannula and IV medication. The cannula is painful. He's never had a cannula in his life before. He doesn't understand why we need to hold his arm still and squeeze it. He doesn't like the concept of needles, and on inserting the cannula, he experiences pain. He needs continuous monitoring and serial ECGs, so leads are stuck to his chest and he's connected up with wires to the monitoring device. And for the ECGs, he needs to try and stay still. You can see how all this is adding to anxiety and worry, because these are procedures which he has not experienced before, and it's distressing for his parents to see him go through this. The IV medication that we need to give is adenosine. Do you remember how patients feel, or how it's described patients feel when they're given IV adenosine? The feeling of impending doom is often described in textbooks, and that is actually what patients feel. Once we administered the IV adenosine, Bobby is full on crying. The team around him tried to reassure him, although in order to maintain trust, we can't promise that we're not going to give that medication again. The members of staff that are around try to comfort and explain to the patients, to the parents as well. We use language, we use distraction, and we use known means of comfort in order to alleviate some of this anxiety and distress. And hopefully you will see some of this happen in the emergency department during your placement. A resting ECG is done after cardioversion, and it's discovered that Bobby has an underlying condition. He has delta waves on his ECG, which means that he has a diagnosis of Wolff-Parkinson-White syndrome. So not only have these parents and this child come in an emergency to the emergency department, we have contributed to some pain and distress through means of treatment and investigation and treatments. And now we have to break unexpected news to the family to say, actually, he's got an underlying condition, which means that he'll need specialist treatment, he'll need further investigations. This is the diagnosis, explaining the diagnosis. and managing any expectations and describing a plan. It's really important not to overemphasize any treatment or plans that will happen, because these might change, and then the parents' expectations of what will happen are not realised, and they feel potentially let down, or plans changing, which it's difficult to cope with a plan that is constantly changing when you are in an acute distressed situation. So I'd like to spend a few moments on reflecting about this case. Think about the communication to the child and communication to the family. Think about how we can manage distress for the child and for the family, and how we can break unexpected news. You've seen some of these in other settings in medicine. For children in unexpected emergency situations, these skills obviously need to be enhanced. You can scan the QR codes to gain further information. It takes you to some articles which describe communication and breaking bad news in emergency departments, specifically in emergency departments. Now we move on to discuss patients with chronic conditions attending the emergency department. Children can have lifelong chronic conditions, for example, diabetes, sickle cell disease, cystic fibrosis, asthma, epilepsy, Hirschsprung's disease, a metabolic abnormality, cancers, and cerebral palsy. And these patients, they have higher health requirements than other members of the population, and can often present with acute illness to the emergency department. And we're going to talk about Sarah. Sarah is a 12-year-old young person. She has cerebral palsy and a gross motor functional classification level of 5. She has a tracheostomy in situ. Her level of expression is limited, so there are some facial expressions that she does to describe joy or pain, but she's non-verbal and cannot move for herself. Her parent and carer present to the emergency department because Sarah has a new fever and has increased secretions. Her mum says, "We came when we knew she was unwell." And that statement in itself describes the parent who knows her child and who knows at what level of deterioration and what they can manage at home and what they need hospital care for. Sarah has had numerous admissions. Her family and Sarah, they know the hospital well, and they are under multiple specialties in the hospital. Sarah's parents and carers understand medical words and have experienced and understand medical procedures. Some patients who have chronic illnesses and chronic conditions will have a personalised escalation plan, which the parents will know very, very well. And sometimes the ED clinicians who have not met Sarah before might not know this escalation plan as well as the parents or carers do. So you can already start to see the differences between this case and with the previous case with Bobby, and in how the emergency clinicians and emergency departments approach needs to be different. And it's more about a partnership of care. The parents and the carers with Sarah in the centre, who know Sarah very, very well. There's the emergency department who they will interact with when they need it. And the specialist teams who provide ongoing long-term care for Sarah and her family. And sometimes the emergency department is the least informed about Sarah and her needs. Always put Sarah in the centre. We have a duty of care to our patients, not the parents. And it's important that Sarah's needs are focused on. But there is a team around Sarah. So her parents and carers, they know Sarah very, very well. And they have an expectation of care from previous experiences. And these experiences might not always be positive. In an acute situation where there's an acute deterioration or an acute need for medical help, the emergency department might not have met Sarah before. So we have to be careful about communication. We have to understand if there is an escalation plan and to try and follow it. And we always have to think about safeguarding in patients who cannot express their own needs and who have ongoing multiple health issues. There's the admitting team or the attending team, which we will need to liaise with. That's the team that knows Sarah better than the emergency department do. And they have responsibility for ongoing care within the multidisciplinary team. And they would recommend changes to treatment plans or the care package if needed. There is also community support for patients who have chronic illnesses in our community. And with a patient like Sarah, there would be already measures in place to support her at home. These need to be reviewed to ensure that they are still in the best interests of Sarah's care. So a lot more complexity and more to navigate and understand with a patient who has a chronic illness or a chronic condition, for example, like Sarah. Again, please scan the QR code. It takes you to some information about understanding emergency medicine in paediatric patients with chronic diseases. This is just some further reading. So I'd like you to spend a few moments now just thinking about that case. Think about communication, think about managing expectations, and how the emergency department would institute any changes to a treatment plan. Okay, so in summary, there are considerations of children in the emergency department in terms of differential diagnoses, triage, pain, safeguarding, spotting the sick child. There are issues with communication in terms of breaking unexpected news or trying to understand the complexities of a patient with chronic illnesses. Remember always that we advocate for the child and for the well-being and for the health of the child. Thank you so much for listening. Next, if you can read the information guidance on what things to look out for when you enter your portfolio reflection. That's on the Teams channel in the file section. As ever, if you have any questions, please speak to the undergraduate department or on shift, speak to the emergency consultant in charge. Thank you so much and see you on the shop floor.